Hey there, future docs! Welcome to another Uber School production. I'm Pete, and today we're diving deep into the world of hemodynamic disorders. Are you ready to crush this section of the USMLE Step 1?
You bet, Pete. I'm Gary, aka Crashes, and I'm here to make sure we don't crash and burn on this topic. Let's get this show on the road.
All right, Crash, let's start with the basics. What's the first thing that comes to mind when we talk about hemodynamic disorders?
Well, Pete, the first thing that pops into my head is edema. It's like when your body decides to become a water balloon, but not in a fun way.
That's a colorful way to put it, Crash. But you're right on the money. Edema is indeed the abnormal accumulation of fluid in tissues or body cavities. It's a key player in the hemodynamics disorder game.
Exactly. And you know what's at the heart of understanding edema? Starling forces. It's like a cosmic balance between hydrostatic and oncotic pressures across capillary walls.
Great point, Crash. Let's break that down for our listeners. Starling forces are named after the physiologist Ernest Starling. These forces determine the movement of fluid between the blood vessels and the surrounding tissues.
Right you are, Pete. On one side, we've got hydrostatic pressure pushing fluid out of the blood vessels. On the other, we've got oncotic pressure, mainly from proteins like albumin pulling fluid back in. When these forces get out of whack, that's when the trouble starts.
Absolutely. Now let's talk about the types of edema. We've got localized edema, which affects a specific area, and generalized edema, which involves the entire body. Can you give us some examples, Crash?
Sure thing, Pete. Localized edema might be something like a sprained ankle. You know, when it swells up like a balloon and you can't fit into your favorite boots? Generalized edema, on the other hand, is more systemic. Think about conditions like heart failure or severe liver disease, where you might see swelling all over the body.
Great examples, Crash. Now let's dive into the causes of edema. We've got 5 main culprits to remember.
Ooh, I love a good list. Hit me with it, Pete.
All right, here we go. Number 1, increased hydrostatic pressure. This is often seen in heart failure. Number 2, decreased oncotic pressure, usually due to hypoalbuminemia. Number 3, lymphatic obstruction. Number 4, sodium retention, common in renal diseases. And finally, number 5, inflammation, which increases vascular permeability.
That's a solid list, Pete. And you know what? I've got a little mnemonic to help our listeners remember these causes. I call it HILLS. H for hydrostatic pressure, I for inflammation, L for lymphatic obstruction, L for low protein, hypoalbuminemia, and S for sodium retention.
That's brilliant, Crash. I'm sure our listeners will find that helpful. Now, let's talk about how edema manifests clinically. What should future docs be on the lookout for?
Well, Pete, the most obvious sign is swelling. But it's not just any swelling. We're talking about pitting or non-pitting edema. Pitting edema is when you press on the swollen area and it leaves a little dent. It's like pressing your finger into memory foam, but way less comfortable for the patient.
Great analogy, Crash. And what about edema in specific areas? Any particular concerns there?
Absolutely, Pete. One of the most dangerous places for edema to show up is in the lungs. Pulmonary edema is no joke. It can cause serious breathing difficulties. Patients might come in with dyspnea or shortness of breath, and it can be life-threatening if not treated promptly.
Excellent point, Crash. Now let's hit our listeners with a USMLE-style question to reinforce these concepts. Are you ready?
Born ready, Pete. Bring it on.
All right, here we go. A 65-year-old man presents with bilateral leg swelling that's worse at the end of the day. He has a history of congestive heart failure. On examination, you notice pitting edema extending up to his knees. What is the most likely mechanism causing this patient's edema?
Ooh, this is a good one, Pete. Let's break it down for our listeners. We've got an older gentleman with a history of heart failure and bilateral leg swelling that's worse at the end of the day. The key here is the congestive heart failure. What does that do to our friend Starling and his forces?
Great question, Crash. In congestive heart failure, the heart isn't pumping blood effectively. This leads to increased pressure in the venous system. So if we look back at our causes of edema, which one fits best?
Well, if we're talking about increased pressure in the venous system, that's going to translate to increased hydrostatic pressure in the capillaries. And what was the first item on our HILLS list?
Hydrostatic pressure. You're absolutely right, Crash. The increased hydrostatic pressure is pushing more fluid out of the blood vessels and into the tissues, causing the edema we're seeing in this patient's legs.
Bingo! So for our USMLE prepping listeners out there, the answer to this question would be increased hydrostatic pressure due to congestive heart failure.
Excellent work, Crash. Now let's move on to our next topic, hyperemia and congestion. These are two terms that often get mixed up, but they're distinct processes.
Right you are, Pete. It's like the difference between a traffic jam heading into the city and one trying to leave, same road, different directions.
That's a great analogy, Crash. Let's start with hyperemia. This is an increase in blood flow to a tissue or organ. It's often a physiological response, like when you exercise and your muscles need more blood.
Exactly, Pete. It's like your body's way of saying, hey, these muscles are working hard, let's give them some extra juice. But hyperemia can also be part of the inflammatory response, bringing more blood to an area that's under attack.
Good point, Crash. Now, let's contrast that with congestion. Congestion is all about impaired outflow. It's like a traffic jam trying to leave the city, as you mentioned earlier.
Right on, Pete. And just like traffic jams, congestion can be acute or chronic. Acute congestion might be something like putting on a tourniquet. Blood flow in is normal, but it can't get out. Chronic congestion, on the other hand, is often seen in conditions like heart failure.
Excellent explanation, Crash. Now, let's talk about how congestion affects different organs. Any particular examples come to mind?
Oh boy, did they ever. Let's start with the lungs. Pulmonary congestion is a big deal. When blood backs up into the lungs, it can cause all sorts of problems. Patients might come in complaining of shortness of breath or a cough.
Absolutely. And what about the liver? That's another organ that can be significantly affected by congestion.
Good call, Pete. Hepatic congestion is fascinating. When blood backs up into the liver, it can create what we call a nutmeg liver. It's named that because when you cut into the liver, the alternating patterns of congestion and normal tissue look like the inside of a nutmeg.
Great description, Crash. It's important for our listeners to remember these organ-specific effects. Now, let's throw another USMLE-style question their way. Are you ready?
Always ready, Pete. Let's see what you're out for us.
All right, here goes. A 70-year-old woman with a history of chronic heart failure presents with worsening dyspnea and bilateral leg swelling. On examination, you note jugular venous distension and hepatomegaly. Which of the following best describes the liver changes you would expect to see on microscopic examination?
Ooh, this is a good one, Pete. Let's break it down for our listeners. We've got an older patient with chronic heart failure, which is key here. She's showing signs of right-sided heart failure with the jugular venous distension and leg swelling. And remember what we just talked about with liver congestion?
Absolutely, Crash. We mentioned the nutmeg liver. Can you explain what that would look like microscopically?
Sure thing, Pete. In a nutmeg liver, you'd see dilated and congested central veins and sinusoids. The areas around these congested vessels would show signs of hypoxic injury, or even necrosis, while the areas closer to the portal triads would look relatively normal. This creates that characteristic alternating pattern we talked about.
Excellent explanation, Crash. So for our USMLE preppers out there, the answer would be dilated central veins with surrounding hepatocyte atrophy and necrosis, alternating with areas of normal hepatic tissue.
Spot on, Pete. And here's a little crash course tip for our listeners. Remember CVN for chronic venous congestion. It'll help you recall the central vein changes and necrosis in nutmeg river.
That's a great mnemonic, Crash. Now let's move on to our next topic, hemorrhage. This is a big one, and it's crucial for our future docs to understand.
You're not kidding, Pete. Hemorrhage is no joke. It's basically when blood decides to take an unscheduled vacation outside of the blood vessels.
That's one way to put it, Crash. More formally, hemorrhage is the escape of blood from blood vessels. It can be external, which is visible on the body surface, or internal, occurring within the body.
Right you are, Pete. And let's not forget, hemorrhage can range from a tiny bruise to a life-threatening situation. It's all about location, 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 and quantity, of course.
Absolutely, Crash. Now, what are some common causes of hemorrhage that our listeners should be aware of?
Well, Pete, the big three that come to mind are trauma, vascular disorders like aneurysms, and coagulation abnormalities such as hemophilia. It's like the unholy trinity of bleeding causes.
Great list, Crash. Now, let's talk about how hemorrhage presents clinically. What signs and symptoms should our future docs be on the lookout for?
Good question, Pete. With acute blood loss, you're going to see the classic signs of shock, hypotension, tachycardia, and pallor. It's like the body's way of saying, hey, we're losing precious fluid here.
Excellent point, Crash. And what about chronic blood loss? That can present quite differently, right?
Absolutely, Pete. Chronic blood loss is sneakier. It often leads to iron deficiency anemia. Patients might come in complaining of fatigue, weakness, or shortness of breath. It's like their body is running on fumes.
Great explanation, Crash. Now let's talk about the consequences of significant blood loss. This is where things can get really serious.
You're not kidding, Pete. Significant blood loss can lead to hypovolemic shock, which is a medical emergency. If it's not addressed promptly, it can lead to organ failure and even death. It's like the body's plumbing system is running dry and all the organs are crying out for help.
That's a vivid description, Crash. It really drives home the importance of recognizing and treating hemorrhage quickly. Now let's hit our listeners with another USMLE style question. Are you ready?
Born ready, Pete. Let's do this.
All right, here we go. A 25-year-old man is brought to the emergency department after a motor vehicle accident. He is confused and his skin is cool and pale. His blood pressure is 80/50ths of a millimeter of mercury and his heart rate is 120 BPM. What is the most likely underlying mechanism causing his symptoms?
Oh, this is a good one, Pete. Let's break it down for our listeners. We've got a young guy who's been in a car accident, so trauma is a big red flag. He's confused, has cool and pale skin, low blood pressure, and a rapid heart rate. What does that sound like to you?
Well, Crash, those are classic signs of shock, and given the history of trauma, we're likely dealing with hemorrhagic shock here. The body is trying to compensate for blood loss by increasing heart rate and constricting blood vessels, which is why the skin is cool and pale.
Spot on, Pete. So for our USMLE preppers out there, the answer would be hypovolemia due to acute blood loss. The low blood volume is causing inadequate tissue perfusion, leading to all these symptoms.
Excellent explanation, Crash. And here's a Pete's pointer for our listeners. Remember the shock triad, hypotension, tachycardia, and signs of poor tissue perfusion like confusion or cool, pale skin. It'll help you recognize shock quickly in clinical scenarios.
That's a great tip, Pete. Speaking of great tips, did I ever tell you about the time I met Marcus Cooper? Now, there's a guy who knows a thing or two about quick thinking and emergencies.
Marcus Cooper? The name rings a bell, but I can't quite place it. What's the story there, Crash?
Oh man, Pete, you won't believe this. So Marcus Cooper was this medical student I met at a conference a few years back. During one of the lunch breaks, a fellow attendee started choking on their food. Without missing a beat, Marcus leaped into action. He performed the Heimlich maneuver so smoothly you'd think he was dancing. But here's the kicker. While he was saving this person's life, he was simultaneously reciting the entire coagulation cascade backwards. It was like watching a medical superhero in action.
Wow, that's quite a story, Crash. Sounds like Marcus Cooper is quite the character. But speaking of the coagulation cascade, that's a perfect segue into our next topic, thrombosis. Shall we dive in?
Absolutely, Pete. Let's get this clot party started.
All right, Crash. So thrombosis is the formation of a blood clot within a blood vessel. It's a crucial concept for our future docs to understand. Can you kick us off with the basics?
You got it, Pete. When it comes to thrombosis, it's all about Virchow's triad. It's like the holy trinity of clot formation. Want to break it down for our listeners?
Absolutely, Crash. Virchow's triad consists of 3 key factors that contribute to thrombosis. First, we have endothelial injury. That's damage to the inner lining of blood vessels.
Right on, Pete. Second, we've got abnormal blood flow. This could be stasis, where blood is moving too slowly, or turbulence, where it's all chaotic.
And the third factor, Crash?
That would be hypercoagulability, Pete. It's when the blood is extra prone to clotting. It's like the blood is just itching to form a clot at the slightest provocation.
Excellent explanation, Crash. Now let's talk about the different types of thrombi. We've got arterial thrombi, venous thrombi, and cardiac thrombi. Can you elaborate on these?
Sure thing, Pete. Arterial thrombi are like the speed demons of the clot world. They're typically platelet-rich and often associated with atherosclerosis. They form in high-flow areas and can cause immediate trouble.
Great description, Crash. And what about venous thrombi?
Venous thrombi are the couch potatoes of the clot family. They often form in areas of stasis, like in the deep veins of the legs when someone's been immobile for a long time. They're more fibrin-rich than their arterial cousins.
Excellent analogy, Crash. And finally, cardiac thrombi?
Cardiac thrombi, the heartbreakers of the bunch. These can form in the atria, often in patients with atrial fibrillation, or in the ventricles, usually after a heart attack has damaged the heart wall.
Great overview, Crash. Now, let's talk about the clinical significance of these thrombi. Why should our future docs be concerned about them?
Well, Pete, thrombi are like ticking time bombs in the circulatory system. An arterial thrombus in a coronary artery, that's a recipe for a heart attack. A venous thrombus in the deep veins of the leg, that's putting the patient at risk for a pulmonary embolism if it breaks loose.
Absolutely right, Crash. The location of the thrombus really determines its danger. Now, what are some risk factors for thrombosis that our listeners should be aware of?
Great question, Pete. Some key risk factors include immobilization, think long flights or hospital stays, recent surgery, cancer, and certain genetic conditions that make the blood more prone to clotting, called thrombophilias.
Excellent list, Crash. Now, how do we diagnose and treat thrombosis?
Well, Pete, diagnosis often starts with a good old D-dimer test. It's like a smoke detector for clots. It might not tell you exactly where the fire is, but it lets you know something's burning. If that's positive, we move on to imaging studies.
Great analogy, Crash. And treatment?
Treatment typically involved anticoagulation, Pete. It's like putting the brakes on the clotting cascade. Depending on the situation, we might use heparin, warfarin, or some of the newer direct oral anticoagulants.
Excellent summary, Crash. Now let's hit our listeners with another USMLE style question. Are you ready?
Born ready, Pete. Bring it on.
All right, here we go. A 45-year-old woman presents with sudden onset of shortness of breath and chest pain. She recently underwent knee replacement surgery and has been recovering at home. On examination, she is tachycardic and tachypneic. A CT angiogram reveals a filling defect in the pulmonary artery. Which component of Virchow's triad most likely contributed to this patient's condition?
Ooh, this is a good one, Pete. Let's break it down for our listeners. We've got a patient who recently had surgery and has been recovering at home. Now she's got sudden shortness of breath and chest pain, and imaging shows a pulmonary embolism. What's the key here?
Well, Crash, the recent surgery and recovery at home are big clues. What does that suggest about this patient's activity level?
Bingo, Pete. She's likely been pretty immobile while recovering from that knee surgery. And what does immobility lead to in terms of blood flow?
Stasis. The blood in her leg veins has probably been moving pretty slowly, increasing the risk of clot formation.
Exactly. So if we look back at Virchow's triad, which component does this fall under?
That would be abnormal blood flow, Crash. So for our USMLE preppers out there, the answer to this question would be abnormal blood flow, stasis, most likely contributed to this patient's condition.
Spot on, Pete, and here's a crash course tip for our listeners. Remember, surgery for stasis under recovery gives embolism risk, yeah? It'll help you connect postoperative immobility with the risk of venous thromboembolism.
That's a great mnemonic, Crash. Now let's move on to our next topic, embolism. This is closely related to thrombosis, but with an important twist.
You got that right, Pete. If thrombosis is the party, embolism is the after party, and it's happening somewhere else entirely.
That's one way to put it, Crash. More formally, an embolus is any intravascular mass that travels from its point of origin to a distant site. Can you walk us through the different types of emboli?
Absolutely, Pete. First up, we've got thromboembolism. This is the most common type where a piece of a thrombus breaks off and goes for a joyride in the bloodstream.
Great start, Crash. What other types should our listeners be aware of?
Well, we've also got fat embolism, which is often associated with long bone fractures. It's like the bone marrow decides to go on an unscheduled field trip through the bloodstream.
Excellent description. Any others?
Oh, we're just getting started, Pete. We've also got air embolism, which can occur during surgery or trauma. It's like someone left a window open in the circulatory system and let a draft in.
That's a vivid analogy, Crash. And let's not forget about amniotic fluid embolism.
Right you are, Pete. Amniotic fluid embolism is a rare but serious complication of childbirth. It's like the amniotic fluid decides to crash the circulatory party, and things can get ugly fast.
Great overview, Crash. Now, let's focus on one of the most critical types of embolism, pulmonary embolism. Can you walk us through this condition?
Sure thing, Pete. Pulmonary embolism is like the bogeyman of the embolism world. It typically arises from a deep vein thrombosis in the legs. A piece of that clot breaks off, travels up through the heart, and gets lodged in the pulmonary arteries. It's like a game of vascular pinball, but with much higher stakes.
That's a great description, Crash. What symptoms should our future docs be on the lookout for with pulmonary embolism?
Well, Pete, the classic triad is sudden dyspnea, chest pain, and tachycardia. It's like the body's way of saying, Houston, we have a problem. But remember, PE can be sneaky. Not all patients will present with all these symptoms.
Excellent point, Crash. Now, let's talk about systemic emboli. These can originate from the left heart or proximal arteries. What kind of trouble can they cause?
Oh boy, Pete. Systemic emboli are bad news bears. They can cause all sorts of mischief depending on where they end up. If they head to the brain, you're looking at a stroke. If they decide to vacation in a limb artery, you've got limb ischemia on your hands or legs, as the case may be.
Great explanation, Crash. Now, there's one more type of embolism I want to make sure we cover, paradoxical embolism. Can you explain this phenomenon to our listeners?
Paradoxical embolism, the plot twist of the embolism world. This is when a venous thrombus somehow ends up in the arterial circulation. It's like a clot that took a wrong turn at Albuquerque and ended up on the wrong side of the tracks.
Colorful as always, Crash. But how exactly does this happen? What allows a venous clot to cross over to the arterial side?
Well, Pete, for this to happen, you need a right-to-left shunt. The most common culprit is a patent foramen ovale, or PFO. It's like a secret passage between the right and left atria that's supposed to close after birth, but sometimes doesn't get the memo.
Excellent explanation, Crash. Now, let's hit our listeners with another USMLE style question. Are you ready?
Ready and raring to go, Pete. Let's do this.
All right, here we go. A 30-year-old woman presents with sudden onset of right-sided weakness and aphasia. She has a history of deep vein thrombosis and was recently diagnosed with a patent foramen ovale. What is the most likely explanation for her current symptoms?
Ooh, this is a juicy one, Pete. Let's break it down for our listeners. We've got a young woman with sudden neurological symptoms, right-sided weakness, and aphasia. That sounds an awful lot like a stroke, doesn't it?
It certainly does, Crash. But what's interesting here is her history. What do you make of the deep vein thrombosis and patent foramen ovale?
Well, Pete, that's where things get interesting. Remember what we just talked about with paradoxical embolism? We've got all the ingredients for a perfect storm here. A DVT that could be the source of a clot, and a PFO that could provide a pathway for that clot to cross from the venous to the arterial circulation.